A really exciting session about shared medical appointments. And the reason it's so exciting to me is the holy grail in doing this work is how do we pay for it in a sustainable way? And the folks you're going to hear from today at Waco Family Medicine are doing this work. And the way they do it is through shared medical appointments. And those are evidence based, reimbursable clinical encounters in which healthcare is offered and delivered in a group setting by qualified healthcare providers. It's an interdisciplinary care team, and they're going to share their experience implementing the model. And they're now on a second cohort, so lots of learnings. Through the model, they bring nutrition and food, physical activity, and social support to patients while also achieving the triple aim of enhancing patient experience, improving population health, and reducing costs. So please join me in welcoming Dr. Alex Jones Adeshina. She is the Chief Impact Officer at Waco Family Medicine, and her primary role is to set the vision of equitable healthcare delivery by managing programs that address social drivers of health, maternal health outcome, and other staff equity initiatives. Her ongoing vision is to make transformational systems change to eliminate health outcome disparities while caring for patients throughout their lives. So over to you, Dr. Adeshina.
Well, thank you for that kind and warm welcome and introduction. I do want to spend a little time introducing my colleagues, Michelle Fairley, who is our care manager and works with me closely both in my patient panel and as well as with our shared medical appointments. So Michelle Fairley, as well as my other colleague, Ray Lucas, who is our fitness advisor and one of our longest running staff members in our work towards non-medical drivers of health work within our organization. And so really delighted to have both of them with me to share this material with you guys today. So thank you, Ray and Michelle. Okay, with that, I'm going to go ahead and dive in. I know this will be a packed hour and want to make sure that we get the most out of our time together. So the things that I wanted to highlight today, what we'll cover today, are our implementation and integration strategy, how we enhanced interdisciplinary collaboration, and most importantly, how we make sure that we are fully able to be reimbursed for the work that we're doing. But before we dive in, I just want to share a little bit about who we are at Waco Family Medicine. So we are located, as our title, as our business organization is called, right in the center of Waco. But we do have outlying clinics in both Hillsborough and Temple. So we span 3 different counties. Our patient demographics do mirror what we see in the state of Texas and as a city overall. So a fair number on our predominant population identifies as Hispanic, and about a third are white and Black, respectively. About 40% of our patients are Medicaid insured, about 33% are uninsured, 10% Medicaid. And we exist to improve the health and wellness of the underserved residents in the heart of Texas.
Dr. Adeshina, if you want to go ahead and share your screen.
I thought I was sharing. I'm sorry.
That's okay.
Let me go back here. I apologize, everybody.
Not a problem.
Okay, can you see it now?
Yes.
Okay, perfect. Sorry about that. Let me go back and show you our pretty building pictures. So this is where we are, and this is the map of where we exist. So, okay. So the overview of the programs that we have in our organization before we started our SMAs really spanned the full breadth of the various NMDOH sectors that we know exist. So of course we've had healthcare for quite a long time, and we really wanted to expand and connect our healthcare programs as well as the programs that address socioeconomic factors and health behaviors. And so that's how we arrived at those programs. As I alluded to earlier, we have been in this work for many years. And so this really was our next step in envisioning how we can make sure that this work is sustainable. And our first program was launched back in 2017. The problem, as we've stated before, is that as much as we know that these programs really make a difference for the overall health of our patients, they're not always independently reimbursable by our payers. And I suspect that with changes at the federal level, this is only going to become more challenging. So that's what brought us to shared medical appointments. It was a way to address medical and non-medical gaps in care. All right, so why did we do shared medical appointments? Our program goals were twofold. How can we do a better job of connecting medical and non-medical gaps that affect our patients' health, as well as making sure that we had a reimbursement potential for our services that otherwise aren't independently reimbursed. And so born sort of out of our understanding of what centering is, where you have a prenatal provider with a group of patients with similar gestational ages working together to improve the group's care, we took a similar model and said, okay, let's do a physician, a group of patients, and a specialist in either culinary education or fitness advising to really help our patients get all of those important things. And so what is a shared medical appointment? It's a care model that improves access to medical care and non-medical services. We decided to focus ours on patients with diabetes because it gave us a core way to really hone in on what were the core characteristics that we needed for those patients to have. And the benefits, like I said, is that it allows us to address both medical and non-medical gaps. And why now? Well, we were at a point where we felt like we had developed many of our programs through existing grant funds. And so we wanted to get to a point where we could be good stewards of that grant funding by graduating ourselves to a place where we could participate and find reimbursement to ensure that we had sustainability. So I wouldn't recommend this if you haven't, had many years kind of honing those skills and deciding how it works best for your patient population. All right, so phase one, this is where we'd really developed out how we were going to make this work. And so we developed work groups that were really focusing on each component that you see here at the bottom. So we had a team that was fully devoted on how do we make sure that this is an interdisciplinary program where we take not only the clinician, the care manager, fitness advisors, and chef educator and make those effective teams. We had a team that worked from the beginning with our billing and reimbursement specialists to really think through what were the ways that we can seek reimbursement. We had a team that focused on, okay, well, how are patients going to get here? What's the clinical workflow that's going to work as we do this, knowing that it's a novel systems level model? And then what's the curriculum? What are we going to actually talk about with our patients in the sessions that we have with them? So really had to map all of that out very early on. And it took a large team, as you can imagine. You saw those groups with the tasks that we had to achieve. And so this here is just a list of the people who were involved at different points. And so there was a lot of interdisciplinary and truly interdepartmental collaboration to get to the point where we really could put this together. That process did take us 6 months. And so again, not something that could be put together quickly, but we really wanted to get it right at the front end so that when we launched it and we had our first cohort, we really were set up for success. All right. As I said, the big component, one of the key goals was really understanding how are we going to bill and be reimbursed for this. And so that was one of our very first meetings that we had. And when we sat down with our billing specialist, they gave us a lot of things to think about. And primarily, we talked through who can bill. And once you identify who can bill and be reimbursed, we then made some critical decisions. And so there's 4 provider types that most payers will reimburse for their services. A clinician, right? So a doctor, whether an MD or a DO, a physician assistant or a nurse practitioner. You can also have nutritionists can also bill for medical or non-medical nutrition therapy. We can bill under care management, and then we can also bill as an enabling provider. And so it really became a question of, at that time, what billing providers did we have access to and which ones were set up in our system and ready to be able to bill. And so when we did that, it was, there were some limitations to each of those and certainly varying levels in terms of how much we would be reimbursed for each of those. So that was the other kind of key component was, where are we going to get the best reimbursement based on the clinician or the provider type that we chose? And we landed with our clinician because, of course, we'd had those from our inception, and care managers who had been doing their work with it for about a year at the time that we first launched this program. The second step in understanding how we bill was understanding how are we going to bill for time, or are we going to bill for medical decision making? And so just to take a brief course, because I know that we often have a mixed room in terms of understanding how clinical billing works, I'll just take a little deviation here. So regardless of how the clinician is seeing the patient, any patient, either one-on-one or in a group encounter, there are two ways that we can decide how much you're going to get paid for the time that you spend with the patient, or for the visit that you've had with that patient. You can use a time criteria, and it's literally based on the time that you start doing work for the patient and the time and when the time ends that you've worked with that patient, or you can do it based on medical decision making, which really gets at medical complexity. And so you'll see the same codes really used for both things, and that code is going to say the extent to which you'll be reimbursed. So for a 15-minute appointment or an acute visit like a cold, a flu, since we've seen a lot of that in the last several months, that would be one billing code. A 25-minute appointment or a chronic follow-up with 2 or more issues can be 25 or a 99214. A 40-minute visit or a critical illness of something that could be so bad that it needs to go to the hospital is our highest level of billing in primary care, and that's a 99215. And so as we spoke with our billing specialist, it was really clear that part of what would make it hard to bill for time is, for auditing purposes, it might raise flags if we were able to see 20 or 12 visits, each of 40 minutes long, even though that was the length of the shared medical appointment. And so really trying to avoid any auditing concerns, we decided to use based on medical decision making, which was pretty easy to know that we were almost always going to be able to bill at least a 99214, again, because these are patients that all have diabetes. And we're actually working on what we were doing. And so we can bill for the counseling that we do. We can bill for all of the diagnoses that are affected positively by the fact that we're doing these shared medical appointments. And so it can make a really easy, straightforward case for using medical decision making. Okay, now, of course, there's always the question of how do you document, especially when you do have multiple provider types in the room. And so there were sort of 3 key components that we needed to include. So of course, we have to put a little bit of history. You do need a physical exam and an assessment in plan to kind of hit those 3 major buckets, but what's included in those actually doesn't need to be terribly lengthy or robust. And so for the history and physical, we often just said, here's what we're doing today. It was a group visit. Here's what the topic that we're focusing on, either fitness advising or chef education, culinary education. And then the physical exam, we just talked about how they looked today. Were they engaging with the group? Were they engaging with their other patient colleagues? And then the assessment and plan, just sort of saying the summary of the counseling that we did and what the major takeaway points were. We did use at least 3 of their chronic diagnoses that we thought were positively impacted. And if somebody was due for labs or other orders, those things could also be included in the same visit. Because we're a federally qualified health center, we do have separate billing rules, especially for Medicare and Medicaid, that sometimes don't always apply. But other codes that could be considered for the counseling component of the shared medical appointments are 99401 and 99402. Again, those are time-based counseling codes. And so you'd have to really work with your billing specialist to know if those could apply for certain of your patients. Okay. And then, so that was billing for the visit itself, but don't forget, we have a care manager who we noted was a billable provider. And so we wanted to make sure that we were billing for the care management that it takes to make sure that our patients are able to access the program and to really engage well. And so those care management services were also billed, and that increases the billable time for the SMAs. So we were able to bill for the time that it takes to help our patients arrange transportation, as well as for the time that they engage. And so that's positive for our care managers, because of course that increases their overall billable time, and it really we leverage our electronic health record to make that work. All right, so phase 2. After we did all of that, we got to the point where we were ready to launch. And so we did go ahead and lead those shared medical appointment sessions. And so those were set up as 5 different group visits where we alternated nutritional education with a cooking session, as well as fitness advising for our patients who have diabetes. And so first we had to recruit. We recruited from my patient panel of patients that met the criteria, really being only that they have diabetes and were not terribly well controlled. And Michelle and I worked really closely to manage their care. So Michelle, would you like to add anything in about how you helped manage their care?
Yes. So I just made sure that they had transportation to get to the facility. their clinic was in the east part of town. The main clinic was in the north part of town. So transportation was really a big issue for them. So I just helped call their insurance company to make sure they had rides. If they didn't have rides, we have Uber Health. I helped them set up with Uber Health. And also we provided food for them at the clinic because we have a mobile truck that comes and delivers food for us. So I also make sure they had food, paperwork of what they can eat, what they can't eat when they was on diabetes, as it was given in the cooking classes as well. So during the SMA sessions, we had, as Dr. Jones said, we had 5 sessions. We had Ray, who was our fitness coordinator, and our chef that put these classes and these exercise together. So we introduced them to the DASH diet. First, we made them sign consents that they was willing to participate in the program, which we didn't have any objection to that at all. And then so we introduced them to the DASH diet. We gave them what salt to eat, what not salt to eat, things like that. And then we had the training classes where Ray came in and she provided them with resistance bands. We exercised, and she also showed them things that how they can just stand up or sit in a chair and not have to be physically fit to do all these exercise. So they was given resistance bands and things like that, reducing salt and sugar, fat cooking demonstration. So again, they taught them what salt to use. A lot of people don't know that the table salt is bad for them. So we taught them the garlic powder, onion powder, things that can help them cut down their sodium intake. And then we also had another class, strength exercising class that Ray provided as well. So you can do a kind of exercise at home if they couldn't come to the gym, to the wellness center. But we did have people come to the wellness center after these SMA classes. So I did provide them with transportation to get to the wellness center as well. And then at the last session, we just did a wrap up of what they learned. They got resistance bands to take home. They also got all the food that was provided in the classes to take home with them. We told them about the farmers market that we have in town and where that was located at and what they can get at the farmers market. And I also provided transportation to if they wanted to get to the farmers market to get food, but they also was provided everything that we did in the SMA appointments.
So after the end of the program, what we did was we really wanted to understand sort of how things had gone. And what we noted was that patients really enjoyed the shared medical appointments. It really improved our patients' sense of community. And in fact, 2 of our patients in our first cohort realized they were related to each other. So that was kind of a fun finding. And we realized that like this was good for us as the people who come in and work in our organization day to day, that it gave us a different way to engage our patients, and one that felt less clinical and a lot closer to what we always envisioned when we came into the profession. The good news is that our patients' health outcomes also did improve. I actually saw 2 of the patients that were in this first cohort earlier this week, and they continue to have well-controlled diabetes, even almost a year out from when we first launched this program. Some of the unexpected findings were, of course, that when we schedule, things really matters for patients. And so because this was an older population, they were typically able to come during the day. But if you schedule something on the first, that might change a little bit. And so certainly some of those things were really important. And successfully, we were able to be reimbursed for all of the patients who were in this cohort. So that was really exciting news. All right, so our next steps. So we know that we have actually, as we mentioned earlier, we have just started our second cohort, and I'm really excited for Ray to share what has been happening with that one. And with the intention that now we were going to expand the payers that we included in the cohort. Our first cohort only had our WellMed or Medicare patients included in that, because we figured if they would pay for it, then all of our other payers would pay for it. And we worked really hard to continue to integrate our other enabling providers into the electronic health record. And so Ray will talk a little bit about her experience getting onto the health record, and now what that means for her being able to bill individually without an SMA. I think really interestingly, this was really what helped us to launch and to think differently about how NMDOH work in our organization could be its own department, with this sort of as our foundational structure. So Ray, will you share a little bit about what's been going on since in this new cohort?
Yes, definitely. So we started our second cohort actually just last week, and we're using patients from a different provider, from a different clinic, and then we also have a new chef educator. So it's been really fun to get to know them and work with them. A couple of changes we did make is during this first session, we did them every week. We learned that wasn't very conducive to a lot of people's schedules. So we switched it to do it every other week this time. So we're going to see how that goes. And we went from 5 sessions to 6 sessions. So we're actually having 3 cooking sessions instead of 2. We'll still have the 2 exercise sessions. And then the 6th session will still be that wrap up session. Other exciting things that have happened since this first phase was me and the wellness center. So we have an on-site gym at one of our clinics at our main site, and we were able to get myself and my staff on Epic, so we can now track wellness center visits, and we can also log time for chronic care management, which has been very exciting. So just a new way to start billing for these services. And we also worked with our Epic team to get all of the shared medical appointments in Epic as well. They all have their own, I don't know the Epic terminology, smart sets, wording, whatever that is. And we were also able to work with our patient services representatives to help us with checking patients in and out. So we have a lot smoother workflow now, which is very exciting. And we are having mixed payers this time instead of just working with the Medicare.
All right, so now that we've done our first cohort and we're at the beginning of our next cohort, now we have enough information that we can start to sort of build out an anticipated pro forma of what we need to do to support the whole NMDOH department based on our SMAs. And so, you know, if you'll recall back to the various programs that we have, these are the Wellness Center, our culinary education, our community resource marketplace, are programs that we have included as being cost covered by the reimbursement for the SMAs that we're doing. Programs that weren't included were programs for women and children and care management, mostly because those services have already documented ways to receive reimbursement. And so we know based on the information that we had from our first cohort that we need to do about 55 cohorts per year to fully fund all of those other programs. But as you hear Ray say, we're beginning to explore the potential that our wellness center may not need to be fully supported by SMAs because they can bill for chronic care management time just for the time that they spend with our Medicare patients with fitness advising outside of an SMA. So really exciting work for us that we are starting to see the fruits of our longstanding labor pay off as we begin to explore and put together the different pieces of what's available to offset the work that we're doing. So with that, I want to open up the floor for questions and see what things you would like us to spend a little bit more time talking about or can explain further.
Thanks so much. This is really amazing and interesting. I'm going to open it up with one question, and then thanks, Cindy got hers answered in your remarks. So other people start popping up with questions. So how are your providers responding to the new billing guidance? Is it like a seamless integration into the billing workflow? Are there obstacles? What kinds of considerations have come up?
Yeah, great question. Fortunately, the billing workflows were already pretty much the same because, you know, from a billing perspective, whether we see 10 or 12 patients in a circle, in a group, or in a fitness advising session, they're still, from a billing perspective, it's still 12 different clinic appointments. And so the same usual processes and workflows for billing were the same for this. And so it made it a pretty seamless integration once we decided how we were going to bill for the appointments. From a clinician perspective, I think that simplifies it because we're not really asking them to learn a whole new set of workflows. And so really we've just been seeking out clinicians who really want to take a slightly different approach in terms of caring for their patients in a one-on-one setting with only the resources that are available in a physical exam room, to really thinking about how can we think about patients from a slightly more population health perspective. And so Dr. Rainey, who has been our second cohort provider, has been eager and excited and was asking about how he could engage in our work more than a year before we had a clear path forward. So it was really exciting to loop him in.
Questions from any of the audience, or am I going to have to pop in again? Okay, let's see. Here's a question. Did all of your patient medical plans include transportation? Did Waco Family Medicine have to pay for any of the transportation directly?
Michelle, why don't you answer that one?
Okay, their insurance company paid for their transportation if they had transportation. The tricky part is if they had transportation on their insurance plan. If they had transportation on their insurance plan, then the insurance paid for their transportation to and from the clinic, from, to the clinic, to home, and vice versa. If they did not have transportation on their insurance plan, then we provided Uber Health, which Waco Family Medicine paid for them to get there.
Great. And we've got a question about care managers. What are the credentials required for someone to be able to bill as a care manager?
I am a master level social worker. So all of us are master level social workers.
And I do think my understanding, correct me if I'm wrong, Michelle and Ray, is that it depends on sort of how they view you as an enabling provider. And so Medicare has some guidelines about what can be considered in that. And so it can be exactly like Ray, where it's a master's level fitness advising, and really it's just a matter of how are we engaging with patients. I don't know that I've seen strict credential guidelines, is my understanding.
Okay. So in the beginning, you said you were focused on diabetics as your patient base. And then on one of your later slides, when you were talking about building a department, you were excluding women and children, but earlier on you had said something about women and children. So can you talk a little bit about how you decided which population to focus on, why you decided on that population, and the factors you considered?
Yeah, absolutely. I think that we do very much envision us doing a similar patient cohort of shared medical appointments for patients who are pregnant, and it could be around pregnancy complications. So it might be our pregnant patients with diabetes, or pregnant patients who have behavioral health concerns that are not well controlled. I think for this cohort, given the timing that it takes, and because pregnancy related billing codes are pretty different from our standard, we wanted to start with what was simple. And so our diabetes patients were our simplest, easily definable group of to create that initial cohort. And so we're still thinking through how we do a cohort for patients who are pregnant, because their billing is pretty different from our standard. And there are some logistical things that we have to figure out on the billing side that makes it different. But we definitely have that as a dream to expand there, because we know that there's so much need and benefit that an SMA could provide.
Yeah, I love what you said about you started where it was easy or easier, because so many providers who want to do this kind of work become overwhelmed with, oh my gosh, there's all this stuff out there and we have all this information. And what you did was say, let's just start somewhere that makes sense for us and do it. And you can move to something else later. And I think that's a lesson that's really good for others who want to start this work. You don't have to know everything or be able to do everything to jump in and get started. Okay, we've got a couple of people now showing up in the chat, so I'm just going to call on you. Cindy Lucia.
Thank you, Elena, and everyone, and Dr. Jones. Um, so I'm a healthy, relatively young elder. Elena's laughing. But this kind of program would really benefit me. And I think back when my children were younger and we, were a family of 4 in a unit. And it's one thing for mama to learn or for dad to get special meals, but I could see this really as an incredible way to impact family health and healthy lifestyles for those who don't have a critical diagnosis or a chronic disease. Is there hope or thoughts? I mean, I can see how that would be way down the road once you've addressed those with the higher needs, but is that something that's in the back of your mind? Is this a trend that's happening? Do you know other organizations that are uptaking this? So I know you're leaders in this, but speak a little bit about those who want to stay healthy and also helping a family unit to learn at the same time.
Absolutely. Yeah, I mean, I think we see this as really just where medical care probably should be going, regardless of the level of health. I think from as a clinician, I really loved doing this because it does get us out of the kind of hierarchical feeling that a clinical appointment often has, even when I make my best effort to kind of level the playing field with a patient and not have that hierarchy be a part of the engagement, it's still really hard. And so I think putting it in an environment where it feels more like what you would experience in your day to day helps us to engage in a more effective way. And I think it benefits both the whole component in a much more effective way. And so I think for that reason, I do think that there's a need and a necessity that we move patients who don't have identified medical problems to this as a way that we talk about counseling. And I just think it's more effective counseling, right? If I can help somebody learn how to cook by cooking with them, if I can help somebody engage with exercise by exercising with them, then it's not so nebulous, and it has a lot more concrete component into it. And so absolutely. I would be, and I think from a wellness perspective, it's good for the clinician to not be always seeing patients one-on-one, rushing from one patient room to the next patient room. So I really see this as really achieving all of the things that we want healthcare to be.
So we've got in the lineup for questions, Sandra Cole and then Nicole Wong.
All right, good morning. Can everyone hear me? Wonderful.
Yes.
So I just did have that question whether or not if there was a link in CMS for care management credentialing. I know for sure that there is the CPW case management for children and pregnant women certification where you can go in and enroll with 10 HPPMs and bill uh, for that if that pregnant woman has a chronic condition in reference to her pregnancy. And then let's say once that child is born, you can be a case manager for that child from age 0 up until they turn the age of 18 if they're in school and receiving any of the resource classes. So I know that for sure, but I'm going to do my research and I really do hope it is because trust me, I want to be a part of the team. And thank you, doctor.
Great
Thank you.
attitude. Nicole.
Yes, I think this is super exciting work. I have background in nutrition programs, and so I was really um, glad to hear about like this type of service being reimbursed. Forgive me if this is something you've already shared, but I was wondering about if the reimbursement is only for the 5 to 6 sessions, and if there are any plans or hopes to have like longer or more sessions or a longer program, or even if there's a referral to similar programs where patients can have more of a longitudinal type of service or continued services within this work?
Yeah, absolutely. Well, maybe Ray, why don't you explain sort of how you engage with most of our patients outside of SMAs? Because SMAs is a pretty small part of how Ray and Michelle generally engage with our patients.
Yeah, so I'm a certified exercise physiologist through the American College of Sports Medicine. So at the Wellness Center, we see patients one-on-one. All of our patients are referred to us to our on-site fitness center, and we're actually creating their one-on-one exercise prescriptions, their individualized exercise prescriptions, and working with them one-on-one. And our goal is to get them to where they're exercising what we call independently. So they come in, by that point, they know their exercises, they know what to do, they know how to read their chart, and we're allowed them to come in. They don't have to be scheduled at that point anymore. We're still there supervising, but we want them to be able to, if they go on vacation or if they just want to exercise at home, we want to be able to get them to that point where they're confident in their ability to do so. So that's what we do outside of the shared medical appointments. Like Dr. Jones-Deshna said, that's kind of like its own separate program. And then as far as nutrition, we've partnered with other community partners for different nutrition programs. We have one, I believe it's about to start next month with the health district. Then they're going to come and we have a on-site teaching kitchen as well. So those are kind of things that we do outside of this shared medical appointment.
And we should mention that one of the reasons that we partner for nutrition is because we don't have a staff nutritionist with us. And so that's why for shared medical appointments, we've used a chef educator, and I have done more of the nutrition counseling, whereas other organizations where there are nutritionists on staff could certainly do this with a nutritionist instead of a chef educator, and collectively pick the recipes and whatnot. So all of that is to say the shared medical appointments are really seen as a way to cover the costs of things that sometimes don't have a clear source of reimbursement in a standalone, more traditional one-on-one patient encounter. And so Ray bills for the patients that are eligible for care management. Not all of them are if they're not covered by WellMed. And so again, it's really just about different ways of pulling in whatever funding is available or reimbursement is available in whatever way it comes. So I hope that clarifies kind of how we've been doing things.
Yes, thank you.
Jill Johns.
Hello, everyone.
Hi.
So my question is kind of evolved now. So in regards to the chef educator, is that someone who is also billable?
Say that last part again. I couldn't hear.
The chef educator, are they also billable?
No, the chef educator is not billable. And so that's one of the reasons why we've really honed in on putting them in shared medical appointments. We've had grants that have helped us kind of understand and envision how a chef educator could work in more clinical settings, but it's not billable as of yet. But I think I saw that you had asked about community health workers. And so I just want to comment because we love a community health worker. We haven't yet, mostly because we don't have a community health worker. But this was one of the main ways that we envisioned engaging a community health worker to kind of help us with sort of the ongoing interaction with patients once they've completed SMAs, to check in and say, hey, how's it going now that you've graduated from your 6 sessions? Where else can we loop you in? Where else can we be supportive of your health maintenance?
That's awesome. And I've heard and read that in some instances, a community health worker is billable. Is that something that y'all have found to be true, even if you don't have one?
Yeah, that's what our early research says, both for CPW and I believe for care management.
Okay, thank you.
Absolutely.
So a lot of the folks who are on this call are obviously curious about what you've done. What advice would you give to someone who is in an organization where this might happen, but they need to bring it forward? They need to be the champion. How do you get the buy-in within the organization to even go down this path?
That's a good question. I think it's really about just connecting back to the mission of the organization. I imagine most healthcare organizations see providing high quality healthcare as a part of why they exist. And so for us, it was about kind of combining that with recognizing that clinical care by itself is not the only way that people achieve health. And so if we want to really see our patients achieve high health outcomes, we really have to think more holistically. And so that's how we've approached it. We also talked about, we want to do this work and it's what our patients need. Let's make sure we get paid for it to the best of our ability so that we can continue to do the work for forever in a sustainable way. And then the last way that we really promoted this was from just a staff wellness perspective. I think we were all just giddy the days that we had sessions at the end because, patients feel really good. When does it not feel good to eat well and to exercise? And so, you get the dopamine from that, plus you're in community. So it's just all the things that we know are good for humans. And so it doesn't take a lot of convincing that this just feels good for everybody involved.
Great. If anybody else has a question, let's go on and take it. And otherwise, I'm going to turn it back over to Jackie. Speak up if you've got a question. I see people have put comments in the chat. Thank you very much. Okay, Jackie, back to you. Let's close us out.
Thanks, Elena, and thanks to our panelists for this robust conversation. These convenings and hearing from organizations like Waco Family Medicine are critical to advance NMDOH work in Texas. Before we wrap up, I want to invite all of the healthcare organizations on the call to be a part of our growing NMDOH program index. Louisa is going to drop the link in the chat. For those of you serving patients at healthcare organizations, we want to hear how you're meeting patients' non-medical needs through non-medical interventions, similar to this shared medical appointment approach. We are looking for health systems, hospitals, clinics, and health plans. This is an exciting opportunity for you to showcase the various ways that healthcare is already addressing patients' non-medical needs in Texas. This is the index is meant to be a resource for providers to learn who is doing what for which patient populations. And it can also be a resource for policymakers to see how healthcare systems are meeting patients' non-medical needs and make change in favor of sustainable payment and reimbursement. The program index is going to be as robust as we make it, so I look forward to connecting with each of you. The link for the program index, like I said, is in the chat, so please click on the link and bookmark it for when you can take some time to add your information. You can always reach out to me at jk90@rice.edu for additional questions. Thank you for taking the time, everyone, for joining us today. Look out for the meeting materials coming in the coming days, and we will include a link to suggest ideas for future webinar topics and encourage you to tell us what would be useful to your role in serving the field of practice of the non-medical drivers of health. Thanks, everyone, and have a great day.